Yeah, welcome everybody. I think you must have had a busy day already, and the day is going to its end, and I hope you find some attraction in the contents of this symposium. Me talking about the first step in addressing the disability picture. So, to set up the stage a little bit, I don't want to bore you with a lot of details on the pathophysiology of multiple sclerosis, but to understand the whole picture we are viewing it, I wanted to dwell a little bit on the basic concepts. As you know, the immunopathological cascade that underlies multiple sclerosis is not understood in any detail, but what you are sure about is that T cells enter the CNS, recognize and get reactivated and harm central nervous system structures. That's the simple man explanation for what happens, and the immune regulation that should counterbalance that is not appropriately active in multiple sclerosis. This is exactly our concept that also try to operate with regard to therapeutical interventions. If you look very simple on a summary of what immunologically and pathologically happens, I mean, this is a slide many of you probably have seen, and it assumes that you have three key elements in multiple sclerosis, which is certainly inflammation. It's an inflammatory driven process. It's also regeneration, and that reflects actually the early stages of the disease where you have inflammation followed by regeneration. But this is underlied by destruction. That this starts already very early in the disease, and at a certain time point, mirrored clinically by the secondary progressive phase, the destruction outweighs inflammation and also regeneration. This is the concept of the two phases of the disease. I'm saying this because this has actually developed very clearly over the last years, the last decade, and we are now talking about a window of opportunity where we can affect the disease by immune intervention. So this synopsis is probably also known to many of you, and it integrates actually the different phases we have. We have a preclinical phase, which is immunological and pathological, probably very important, but we're not able to pick that up. And we have the symptomatic phase, also called the CIS, clinically isolated syndrome. This is the first phase, or the first time point a patient actually gets to your office, and you can pick up the diagnosis. And we're not getting tired in emphasizing that this is the most important thing nowadays, to recognize that there is a likelihood that this patient develops full-blown multiple sclerosis after a first demyelinating event, and the diagnostic criteria now allow the diagnosis pretty precisely. And what it's also about is the importance, in addition to the recognition of decision-making in terms of starting therapy, and that's exactly what the talk should be about. Looking here, we like to say this is kind of the point of no return. At one point, the patient starts to deteriorate. We don't know when and how and why, but the deterioration is obviously independent of inflammation. We may have superposed relapses, but they probably don't affect that much the clinical outcome. The key measurement that underlies most of the studies is the EDSS, Expanded Disability Status Scale, and what you see here is the pathological milestones. And when you remember that EDSS of 4.0 is the EDSS score where you can really see that the patient has an impairment in walking distance is limited to 500 meters, you can see that this is a very critical milestone, and this is a milestone reached as in little as in 7 years. So Avonex, the substance that has been introduced in the early 90s to MS therapy, is, with regard to the length it is applicable, an old substance. It's not an old-fashioned substance, and what the talk is also about is what we have made advances in views how this agent affects and impacts the entire disability picture. Interferon beta-1a intramuscularly applicated is indicated for patients with relapsing multiple sclerosis, you know that, and it's also indicated, and that was a big step forward for patients with a single demyelinating event, so patients after experiencing CIS. And this comes back actually to what we assume this early intervention will eventually affect the outcome of the disease. This is the initiation in this, as I already mentioned, window of opportunity. And many data, not only from Avonex, with many DMDs, they support this concept that the earlier the diagnosis is, the outcome in the end is positively affected, and it definitely makes a difference. The later you treat, you cannot regain what you may have lost. And that is actually, to the best of our knowledge, the pathophysiological concept we believe in. So, if you look at the left side of this slide, it comes back to what I have already introduced, this EDSS-4. This is actually the phase where we strongly believe, and this is actually matching many pathophysiological, immunopathological, but also clinical and paraclinical evidences, that the time to EDSS-4 is really most influenced by inflammatory activity. Relapses would indicate inflammatory activity, and the switch from one episode to the next relapse, the time to CDMS, is really affecting that. Beyond that, so the time to 6 and 7 EDSS from on EDSS 4.0 is not very much influenced by inflammatory events. And that should be kept in mind when considering actually the window of opportunity for treatment. The right side is actually an arrow or a wheel depicting the different views in terms of what should be influenced or impacted by any therapy. And that are different aspects clinically and paraclinically. And that I'm going through with regard to the data we have. It's partly a reiteration from older data, but also always referring to this complete picture we want to influence. So this is a famous study because it was the first study to be published with this, at that time, provocative concept to treat patients with a single demyelinating episode. And you all know that Avonex achieved to demonstrate that the principle of early intervention is able to reduce the risk of converting very significantly.